We're also looking for safety concerns that require more than weekly monitoring. When passive suicidal ideation has become a daily companion, or when self-harm has become a regular coping mechanism, or when someone's relationship with substances is escalated to the point of genuine risk, these presentations require a level of monitoring, support, and clinical responsiveness that outpatients simply can't provide. This doesn't necessarily mean someone needs acute inpatient hospitalization, but it does mean that they need more than 1 hour a week of outpatient therapy. We're also looking for somebody who suffered from complete social and functional isolation. When someone is withdrawn so thoroughly from their relationships, their work, and their daily life that they're essentially living in a world of one, that isolation both a symptom and a barrier to recovery. The relational structure of a residential setting, the daily contact with a consistent clinical team, the simple experience of being known and noticed by people who are trained to care. These aren't amenities. This is what treatment is needed. The people who come to Florida Oasis aren't people who gave up too easily. They're almost without exception people who tried everything else first. They've cycled through therapists, sometimes many, searching for the right fit. They've sat across from psychiatrists and adjusted medications more times than they can count, managing side effects that made everything harder, holding on to hope that this combination might finally work. They've done the intensive outpatient programs. They've tried partial hospitalization. They've shown up again and again with a kind of quiet, exhausted courage. And they arrive here carrying something that's almost universal. A deep private belief that they're the exception, that everyone else gets better, and something about them is fundamentally, permanently broken. We want to be direct about this. That belief is a symptom, not a fact. Clinically, our residents typically present with complex layered diagnoses: treatment-resistant depression, complex PTSD, significant anxiety disorders, mood dysregulation, and often a co-occurring relationship with substances that's developed as a survival strategy rather than a lifestyle choice. Many arrive following a recent hospitalization that stabilized an acute crisis but didn't address the underlying architecture of the illness. Others have never been hospitalized but have slowly been deteriorating in outpatient care for years, each week a little further from the life they're trying to get back to. What they share is not a diagnosis. What they share is this: the level of care they've been receiving has not been sufficient for the level of suffering they're carrying. And that mismatch, not any personal failing, is why they're here. There are many residential programs. The question worth asking is not just whether someone needs residential care. It's whether the residential setting they choose is actually designed to meet their specific clinical needs. Florida Oasis was built from the ground up around a single clinical conviction. People heal faster, more deeply, and more durably when they feel genuinely safe, genuinely known, and genuinely involved in their own care. Every structural decision we've made has flown from this conviction. We are a nationally accredited organization, and we admit no more than 9 residents at a time, deliberately and without exception. This is not a marketing choice, it's a clinical one. In a home of 9, our staff knows you, not your chart, you. They notice if you didn't finish your breakfast. They notice the shift in your posture after a hard phone call. They notice when your voice sounds a little further away than it did yesterday. That level of attunement, that capacity to meet someone before the crisis rather than after it, is only possible at this scale. Daily psychiatric access, not monthly check-ins. Our board-certified psychiatrist serves as our medical director and is embedded in the clinical team, not a distant consultant who reviews charts from another building. Your medication is not managed in isolation. It's calibrated in close, ongoing collaboration with your therapist, reviewed in the context of how you're actually living and healing, and adjusted with the goal of supporting your real world function, not simply quieting your symptoms. 42 hours of weekly program built around repetition, not information. The research on acquisition is clear. Knowing a skill and being able to use it under stress are two entirely different things. The gap between them is closed by repetition, coaching, and practice in conditions that approximate real life. Our 42 hours of weekly group programming, combined with 2 individual therapy sessions each week and specialized trauma treatment, including EMDR, is designed to give your nervous system enough repetitions that skills become automatic, not theoretical, automatic. Real-time support in moments that matter the most. This is the structural difference that changes everything. When symptoms come on strongly after midnight, and our residents, it often does, there's a trained clinical professional right there, not on the other side of the hotline, not available tomorrow at your next appointment, present, sitting with you, breathing with you, helping you practice your tools in the exact moment the pain is loudest. That kind of consistent, embodied, real-time support is how your nervous system finally learns at a deeper level than cognition that it's safe to soften. We carry the logistics of survival for you. One of the most underappreciated barriers to recovery is the sheer cognitive and emotional load of daily life. Insurance calls, meal planning, transportation, FMLA paperwork, and the 10,000 small decisions that drain what little energy a person has left. We take all of that off the table. Catered meals, transportation, case management, life skill support, so that every unit of energy our residents have to go towards one thing, and that's what actually matters: healing.